Why don't we start broadcasting? Good afternoon, all. Welcome to today's webinar on staffing considerations for crisis standards of care in the COVID-19 pandemic. We'll get started in just a moment, just waiting for everybody who was waiting to join the webinar to actually be added into the webinar. Thank you for your patience. Okay, good afternoon, everybody. My name is Scott Wallach. I'm a senior program officer at the National Academies of Sciences, Engineering, and Medicine, and have the pleasure to be the staff officer for this project. I'm going to stand in momentarily for the illustrious Dr. Harvey Feinberg, who's the chair of the Standing Committee on 21st Century Health Threats and Emerging Infectious Diseases. Our agenda this morning, or I'm sorry, this afternoon, we'll hear a little bit from our sponsor, Matt Watson from ASPR, and then Drs. John Hick and Dan Hanfling, who are the primary authors of the Rapid Expert Consultation, will provide you with an overview of that document. That'll be followed by a question and answer session. We'll be using the Q&A feature within the Zoom webinar, so we do ask that you please submit your questions in Zoom in the Q&A feature. That'll allow all the panelists to see them as they come in, and we'll be able to answer those when we get there. So let's see, I think Dr. Feinberg just joined us. So actually, Aurelia, I'm going to ask you to go back a slide, and I'm going to turn it over to Dr. Harvey Feinberg.
Oh, thank you very much. Scott, let me just double check. Are you able to hear me?
Yes, we are.
Okay, perfect. Again, thank you for getting started. I'm sorry for the delay on my part, but I am very, very pleased that we have the opportunity today to gather again with all of those who are on this webinar to talk about the crisis standards of care, especially with respect to staffing in connection with the COVID-19 pandemic care for patients. This is a topic that is of enormous consequence and a great moment to many of us, and a source of anguish and challenge for clinicians all over the country where there are high incidence of COVID-19 patients. We're going to be discussing today the document that was prepared under the auspices of the National Academies Standing Committee on Emerging Disease Threats and 21st Century Disease Threats. These reports are part of a series, this latest relating to staffing and crisis standards of care was mainly done in response to a request from the Office of the Assistant Secretary for Preparedness and Response. The main presenters will be the two individuals, eminent emergency clinicians, experts in crisis standards of care, Dan Hanfling and John Hick, who will respectively introduce the elements of the document. But before turning to Dan and to John, I would like to welcome and introduce Matt Watson, who's the Senior Advisor and Hospital Team Lead for COVID-19 Healthcare Resilience Working Group within the Secretary's office. So Matt, could I turn to you for your introductory comments and whatever other you would like to offer at this time?
Sure. And thank you very much for that, Dr. Feinberg. I really appreciate both the opportunity to present just a few words today in introduction, but also really want to convey our gratitude to the National Academies for taking on this critical topic yet again. As Dr. Feinberg eloquently put it, this work on crisis standards of care in this most recent report really is a continuation of years of work on this important topic. And more proximally, as was alluded to, came from a request that we had heard from clinicians on the ground who were struggling in the context of staffing their response to the COVID-19 pandemic. From the ASPR perspective, we certainly intend to continue working with and supporting the clinical community and other on-the-ground stakeholders and responders as they do the important work of safeguarding lives and health during the COVID-19 pandemic, and we are deeply appreciative of all of those efforts. So with that, Dr. Feinberg, I'll turn it back to you. Thank you.
Well, thanks so much, Matt. Really appreciate your being with us. And on behalf of all of us, I want to thank you for your service to our nation, especially at this critical time. Now it's my great privilege to welcome Dan Hanfling and to turn the program over to him. Dan, the floor is yours. Dan, if you're speaking, you may still be on mute. Scott, shall we turn back to you?
Sure.
Perhaps what we can do really is to introduce the problem statement that was really the basis of the work that we're going to be discussing today. So maybe I'll just briefly summarize, which is on the slide that I think we're all able to see, and I hope you're all still able to hear me. Basically, the problem is that qualified staff are not sufficient in number, especially staff related to respiratory therapy and critical care nursing, to meet the needs of patients as COVID-19 cases increase. This is a local problem. It is a problem that expresses itself in particular hospitals and regions. And inconsistent staffing across hospitals within a region and across regions also demonstrate the importance of thinking about this distribution of staffing in a fair and equitable ways. It's very important to be able to prioritize logically and rationally the requests for staffing assistance, and also critical for individuals faced with these urgent choices within an institution to be able to make decisions based on the best available information locally and also clear appreciation of the principles that are at stake. I see that Dan, I believe, is here, but Dan, I'll turn to you if you're able to pick up the presentation at this point. Are you available and able?
Sure. So I apologize for the previous technical difficulties. Can you hear me clearly?
We do now, and thank you.
Okay, thank you, Harvey. So thanks to Harvey and Matt for the introduction and the opportunity to support ASPR in this important work. And actually, I'm going to turn the floor over to John initially to take us through some of the fundamental elements around our overarching framework that describes crisis standards of care. And then we'll get into an overview of both community-wide and then healthcare system-specific strategies. And then I will come in at the end with regards to an overview of some basic milestones and key questions that ought to be considered as you are looking to develop your own staffing approach in the setting of a surge response. So I'm going to hand the baton off to John, and then I will be back on board with you when John has concluded.
Great, thanks, Dan. Next slide, please. So I just wanted to set the stage a little bit here before we start talking specifically about staffing. I think one of the things with crisis standards of care is to remember that we're transitioning from a conventional space where we're using our usual methods of care, our usual staff, to contingency, where through adaptations we're able to provide a functionally equivalent level of care to crisis, where there is a risk to either caregivers because of the type of PPE they're using, or the length of the shift, the risk of burnout, et cetera, or there's a risk to patients for worse outcomes because of how thinly the staff is stretched, how the staff is having to step into areas and domains of treatment that they are not as familiar with. And of the four elements of surge capacity here: system, space, staff, and supplies. Staff is by far the most elastic, and so the bright lines that we can draw with availability of ventilators and beds in a usual ICU and things like that, we really can't draw as effectively with staff. And that makes this particularly challenging to sort out, and it also makes it very challenging from a metric standpoint, because counting staff is of very, very little benefit most of the time, unless you know usual staffing ratios and the size of the facility and other things, and you still don't really know how those staff are being applied across different domains of medicine, from anesthesia to critical care to monitored units and et cetera. The list goes on. So it is difficult often to get our hands around the area of staff as it relates to crisis standards of care, and yet I think it probably was not an area that we prepared ourselves very well for going into COVID-19, preparing staff for those roles, working with our collective bargaining, working with our nursing units, working with our nursing staff, doing the orientation and education and the preparation to know how we were going to use different staff differently, how we were going to set up different schemes of care essentially to, break the current model, because at some point you get to, the cold hard fact that we cannot just pedal faster. We have to actually do things very differently in order to use the staff we have at hand to meet the needs of COVID-19 during a surge. So systems level issues here are very, very important, because if we're not using incident command, if we're not using and leveraging our healthcare coalitions, our healthcare systems that hospitals may be a part of, and really working to load balance, and that goes for both moving patients as well as moving other resources, or potentially deciding about how to allocate limited staff available. It's really important that there be systems in place to manage that information, manage those logistics, manage that patient flow, in order that we don't create inequities within the system, and that we don't have hospitals that may have a full ICU and another hospital has a full ICU, but when you look at it, the staff in one of those locations is absolutely strapped. They're covering a much higher, ratio of patients than the other hospital is, and there may be a very different degree of criticality between those hospitals. One hospital may have 40% of people in the ICUs on ventilator, and another hospital has 95% of patients on ventilators. So very, very different patient population, very different staffing situation, and yet if you looked at the numbers of ICU beds available, they would look pretty much identical. So being able to parse the data and look at the effects within the systems and try to load balance across those is really important to get to some degree of equity and consistency of care across those systems. Space, actually, we have not found to be as much of a challenge as we suspected that it might be, I think, going into COVID-19. I think between post-anesthesia care and monitored units and, using alternate care spaces on hospital campuses, as well as really transitioning away from the use of space in some situations, moving to telemedicine and other applications to, meet our healthcare needs virtually. I think we've really done some things to the point where space has not been, a critical limitation for most hospitals who have suffered through COVID surges so far. Staff we're going to talk about in detail here in the upcoming slides. And then supplies, personal protective equipment continues to be a major challenge for almost every hospital, almost every long-term care, almost every other, healthcare application across the United States. That is something that we will need to, rectify going forward. But I think, fortunately, given that we went into this thinking that supply chains for pharmaceuticals might be irreparably broken, that raw materials might not be available, that we might not have enough ventilators, I think guardedly we can say so far that we have skated clear of major protracted supply shortages. At the same time, we need to be thinking about what are the strategies if we wouldn't have enough, and how do we adapt and substitute and conserve, and if necessary, reallocate resources. But fortunately, I think we are positioned far better than we were several months ago across a variety of supply domains, but we will hope that that holds and continue to work on contingency plans. Next slide, please. So at the community level, I think it's really important when we talk about staff being, very stretched to cope with the patient load. We need to think about why is that patient load occurring in the first place, and what mitigation strategies do we need to do, ranging from essentially a shutdown of most city, societal operations has had to occur in New York City to get their curve under control, to universal masking, social distancing, closure of bars and restaurants, prohibitions on community gatherings of more than X number of people. We have to drain the tub faster than we're filling it, or the staffing situation is going to continue to get worse. And I think that goes doubly when we have young, healthy healthcare staff who may consider themselves to be at low risk and may actually be out and socializing and potentially contracting the disease outside of the healthcare facility. That presents a double whammy to the healthcare system and is something that we certainly want to try to avoid through, good counseling with the staff about the risks of those kind of activities and making sure that we're, really aggressively trying to control those disease curves in the community so that staffing is not pushed beyond its limits. We talked a little bit about load balancing, and I think that is becoming a strategy that is implemented more and more. When you look at Detroit moving over 1,000 patients around their metro area and outside of their metro area, or the fairly Herculean task that was undertaken in California to unload El Centro and Pioneer hospitals of over 625 patients now, to move them out of those very small community-based facilities and distribute them to tertiary care centers around the state. That sort of load balancing, again, is really important when we think about equity and consistent access to a consistent level of care. And so thinking through with emergency medical services and with the operations centers and the healthcare coalitions, how does that construct, how does that medical operations coordination cell concept or MOC concept work in our area, and how would we go about this to make sure we're providing that consistent level of care? Curtailing delivery of elective services and either rescheduling or reworking routine care visits in the outpatient setting, those are two different areas, and we really need to think about different approaches to those. Electives, at a certain point, very few of those remain elective, and at the same time, there's a very narrow category of emergency surgery. So, looking at what are the demands right now on the inpatient sector, and what can we reasonably risk for inpatient capacity based on the elective surgeries that we need to do, whether it's orthopedic procedures or other things. Can we continue endoscopies? Can we continue to do, some of the biopsies and other things that need to get done? There's two decision points there. One is, what is the outcome from a resource standpoint of the case? Is it going to require a medical surgical bed overnight? Is it going to require an ICU bed? But also from a staff and space resource standpoint, can we afford to use the post-anesthesia care space? Can we afford to use those providers for the procedure, for the supervision of the procedure, for post-anesthesia care nursing? Or do we need those providers to actually be working on the inpatient side or taking inpatients actually into those areas of surge capacity? So thinking very carefully about, what procedures we would like to do, and then what do we realistically have the resources to do? Because this is a long haul game, and we can't apply a very blunt instrument here as we might for a mass casualty situation where we just cancel elective procedures for the next 2 days. Well, we're not at liberty to do that for the next 6 months. On the routine care visit side, I think, again, we've really looked at some transformational activities with telemedicine, but it is really important that we continue to provide the support for the chronic care of patients. No question that, we will over time see chronic conditions become manifest as acute medical problems if they're not managed on an ongoing basis. So whether it's flu vaccination this fall, or compliance with antihypertensive therapies, or monitoring of creatinine or electrolytes, those things need to happen, and it's a matter of having the imagination, doing the reach outs, and really going and bringing the care in a lot of cases to the patient if the patient is either fearful, or if the services, the infrastructure doesn't allow us to offer the services in the usual fashion. Think about how we can get those services performed so we don't have those patients paying the price down the line, and particularly if it is a at-risk community, deprived community, communities of color. If you have to take 3 buses to get to the clinic and you don't want to travel by public transport, then you're not going to go. And so making sure we're providing access again is so important for the care of chronic conditions, as well as testing, the availability of vaccine as we get that available, and other things. And then ensuring support for our existing workforce. It's fine to talk about supplemental resources, but if we don't take care of the workforce that we have and make sure we're not overextending them, either pushing them too hard by shift hours or pushing them into levels of responsibility they are clearly uncomfortable with and anxious about, to try to mitigate some of the effect that we're seeing with the very isolated patients who have only their caregivers as any contact with the outside world. The caregivers are the only bridge between the families. It's a very high-stress situation. These are the kind of things that can lead very, very rapidly to burnout and many other difficulties keeping our providers at work. Same thing goes for the schools being out, the need to provide family care, whether it's for your child who's out of school or for a mother who you've decided you will move out of her long-term care facility in order to keep her at lower risk for COVID. So a host of considerations on how we support our existing workforce and keep them at work during this time, rather than look just at external and adaptive resources. Next slide, please. So at the healthcare system level, there's a number of things that can be done in order to help provide some staffing consistency. Mobilizing staff from out-of-hospital entities to assist in hospital-based services. So this could be clinic providers. This could also be providers from medical care delivery systems or ambulatory surgery centers that are not hospital-associated. So if you have a large orthopedics group that does their own surgeries in ambulatory centers, they may have a robust contingent of physician assistants, physicians, nurses, occupational therapists, physical therapists, potentially CRNA and anesthesia staff, post-anesthesia care, healthcare assistants. that could all be mobilized to actually support and assist inpatient care delivery if needed. And that certainly has been done successfully. We've certainly seen some lessons learned from New York City, from some other major areas. Some of the key things, as they always are the onboarding process and adapting to the electronic health record, which for all of us who deliver care at the bedside remains kind of a foreign and chaotic beast, and yet is a necessity these days in providing good medical care. Recruitment of providers not currently in direct patient care roles is important. So even within the hospital environment, you may have educators, you may have paramedic trainers, you might have simulation lab educators that might be able to be pulled back to clinical duties. And it's important to take a look at those, or take a look at those that have a split clinical and administrative responsibility, and move them as much as possible to full-time clinical practice. So determining, what scope of practice or other considerations are there is also important. Adjusting the ratio of providers to patients is certainly a possibility, and so usually we might maintain a ratio of 1 ICU nurse per 2 ICU patients, but if we chose our patients carefully and had stable patients who did not have multi-organ failure, were not in shock, but were in sort of recovery mode on the ventilator, that is certainly something we could expand the ratio to, say, 1 to 4. There's also opportunities to change the model to, instead of an individual nursing approach, to a little bit more of a team-based approach where we have a team of nurses who are responsible at a 1 to 2 or 1 to 4 ratio who are not necessarily critical care providers, but then we have critical care nurses supervising a larger number of patients. We have a hospitalist working with those patient groups, and then we have a critical care physician supervising those hospitalists. So that ratio, and there's an illustration from Society of Critical Care Medicine that illustrates kind of an extreme of that, but ratios that were, gotten pretty close to that in some of the hospitals in New York City, where you had critical care providers looking after, 50 plus patients on their service, and with hospitals working under them to assure that the details of the care, were implemented, and working with the critical care, physician to troubleshoot as the critical care nurses worked with their, the other RNs who usually were floor care, monitored unit, other providers to provide the direct care. And I think, too, just thinking within our hospitals about how staff either step up from, say, a monitored unit to intermediate care, from intermediate care to intensive care, or step over in their practice from, say, being a CRNA to being on a rapid response team, or, if you are a healthcare assistant, maybe you're part of a proning team that goes around and helps turn patients and provides, that workforce. There's a lot of opportunity for a lot of contributions from providers that are not necessarily using their highest level of skill all the time to really operate at that highest level and allow others to come in more of an assistant role and take over some of the other duties. At the same time, if there are duties that are not oriented directly towards clinical benefit for the patients, such as some of the charting that we do. For example, there might be other activities that need to take a back seat, again, some administrative and education and other things may need to be waived, canceled, or rescheduled in order to allow our providers more time at the bedside. And as we mentioned, deploying telemedicine and other digital solutions, not only to provide that primary care opportunity, but to provide critical care medical oversight, or to bring critical care expertise or pulmonary expertise into community hospitals where some patients may need to be moved during intensive care unit overloads. Community hospitals that don't normally provide care for ventilated patients may actually be a great location to continue weaning patients off of ventilators who remain relatively stable from an other organ system function standpoint. And so providing that critical care oversight by telemedicine, that consultation for the weaning process could be of significant benefit in making sure that there are adequate critical care beds available in the tertiary centers. Next slide, please. So at this point, I'll turn it over to Dan Hanfling to talk a little bit about how we might assess some of the interventions that we've talked about.
Yeah, thanks, John. And again, sorry about the technical difficulties earlier. So before I get into the last two slides with regards to assessing the framework, asking some of the key questions, I think it's important to remember, and we are reminded daily, that the toll that this crisis is going to take, or potentially going to take, on the workforce is huge. And we were reminded of this in work that colleagues have done and shared with us in preparation for this webinar from the experience in West Africa with regards to staffing medical services during the Ebola crisis, as well as other disaster events in which the attrition of the workforce becomes a very real concern, largely based on a combination of factors, the top three of which are either fear, fear of infection or fear of exposure, what have you, fatigue, basically being overworked and unable to catch up, and then sort of the related theme of professional or family or other obligations that simply get in the way of being able to continue to serve in the role as a frontline provider. So I think as we go forward, we have to take into account the fact in our business, we often talk about, a disaster response not being a sprint, but a marathon. This is clearly the ultra marathon. And we have to be very cognizant of the risk of attrition and the risk of burnout and the risk that the ongoing crisis presents with regards to our most important resource, which is our staff. So a few final considerations with regards to assessing the implementation of these strategies. And in the paper, we go through a series of these questions, but the ones that we will highlight here are the few that could really, for those of you who are figuring out where to get started in trying to put a staffing plan together for a surge response, this could be your starting point. The first is, again, with regards to reassignment of personnel and whether or not, for example, those staff who might have administrative or education roles can be brought into the clinical arena, either independently because they are comfortable with their clinical skills, or paired with a clinician who can provide some real-time oversight and be a resource to in real time. The second is to remember that many of you belong to health systems and hospitals that are part of healthcare coalitions. And the whole idea of a healthcare coalition was to essentially share the wealth, but also to share the pain. And so if there is an opportunity to reach back within your healthcare system, healthcare coalition, that of course brings together not just hospitals and the out-of-hospital community, but pre-hospital care, EMS providers, and others to see if there are additional staff that might be deployed. And that might include deploying staff outside of their traditional scope of practice, again, with close oversight to assure the safety in the delivery of care to patients. The third key question has to do with staffing ratios and whether those ratios can be adjusted. And the fourth having to do with a transition from individual care to a team-based strategy that potentially allows you a broader array of oversight with regards to the delivery of services at the bedside. Last slide, please. So in terms of making a need, determining a need to make a request, these are the sorts of questions that you ought to consider putting forth and trying to have an answer for before you bring the question forward either to your state or resource, state leadership at the public health department or to the federal partners. And again, this entire monograph and series of webinars was precipitated by just this kind of request from one of the states suffering and undergoing the rapid surge in demand for healthcare services that we've all seen over the last few weeks. So the first, again, is whether or not a load balancing strategy has been implemented, and is there a way to share patients geographically so that there is a recognition that no given institution or region within a state is overwhelmed while other areas still have capacity to be able to deliver a higher level of care. The second key consideration is, again, whether or not some of the strategies that we've just outlined for you over the last 30 minutes, including a tiered supervisory staffing model or a change in staffing ratios, have been implemented, because I think these are the sorts of things that our state and federal colleagues will want to know. And then finally, a key question will be whether there is other evidence of the demand on services for healthcare delivery that can be a little bit more discrete in their description, back to the space, staff, and stuff model, where specifically the use of ventilators or the access to specific medical countermeasures or the total number of critical care patients that any given hospital or region is impacted will be helpful, again, to help provide context for the request for additional staffing. So with that, I think we're going to open up the process to hear your questions. Hopefully, we'll be able to get you answers to those, hear your concerns or other considerations. And it looks, as per the slide, it looks like we're going to use the Q&A feature in Zoom to have you ask those questions. And Scott will help us coordinate that.
Thanks, Dan. Right now, we have no questions in the queue.
So no questions in the queue either means we were all on mute the whole time and we only talked to ourselves, or you guys have
Dan, I think this is Harvey. I think I was on mute. I was just going to comment that first to thank you and John as both for the excellent presentations and for the work that made this possible in building up the presentation. And as people are putting their questions into the Q&A for Scott to monitor for us, I wanted to ask each of you really, you've both had extensive experience in real-time, real-world crises, emergency situations, demanding extraordinary response, often involving adjustments in staffing as well as the other elements that John described. From your experience, is there anything that you personally derive that you say, yes, this is directly germane to COVID, or is COVID so distinct in its scope, its duration, in the nature of its demands that you would say, this is its own thing and we've got to deal with it only on its own terms? So I'd be interested in a comment from each of you about how you see your own past experience relevant or bearing on the current COVID situation. Dan, I see you, so maybe I'll start with you and we'll see if John wants to add in as well.
Sure. No, I think so. Thanks, Harvey. I think it's a really important question because there are many others, I'm sure, who are participating on the webinar today who themselves have also participated in disaster events and have had extensive experience with regards to these sorts of issues. You know, most of the large-scale disasters that I've attended to over the span of my career, for the most part, have been sudden onset, no notice, you know, whether that be due to Mother Nature as a terrorist or terrorists as a terrorist, in the case going back 20 years. And, you know, the one thing about those sort of sudden onset events is that they come to an end. We know that they come to an end. Even the large-scale earthquakes and natural disasters that I've tended to, particularly the challenging triplet of hurricanes in the 2017 hurricane season, did come to an end after a period of time. And I think that in that regard, this is unprecedented, both in the scope, the scale, and the duration. Of course, the last pandemic that we experienced a decade ago, H1N1, in retrospect, really looks like it was no more than a glancing blow. And this is so comprehensive in terms of having to engage the entirety of the healthcare workforce. that I think it is unprecedented and therefore all the more challenging.
Well, thank you, Dan. John, do you want to add a word from your perspective and experience?
Well, thanks, Dr. Feinberg. I think one of the things that we have either the luxury or the curse of with COVID-19 is time. As Dan says, we get pretty used to the no-notice events, and people, because of the need of the moment and the adrenaline, they are willing to step up and do things. Dan recounted our last webinar, and I think it's a great example of a pediatric surgeon in Las Vegas that scrubbed in as a scrub nurse because they didn't have scrub nurse available. And that's the kind of thing you just do in the moment because it's the right thing to do. With COVID, because it's such a slow roll, I think we have the opportunity to think and to fear and to apply processes and reflect back to job descriptions and other things that sometimes don't allow the degree of flexibility of job roles that we might need during this event over a longer term. But negotiating those in the time frame that we have gets a lot more difficult than when there's a really clear, obvious need and people are just going to have to step up and step in. So I think sometimes the luxury of time can actually, work against us, and I think in some cases that's what we're seeing here. But I think, part of that goes along with a legitimate fear on the parts of providers for their families, for themselves, of contracting COVID. Trauma is not infectious, even though stress is, and we certainly see that, in mass casualty events. The kind of prolonged sort of burning anxiety and low-grade stress about potentially contracting the disease or bringing it home, to your kids or your mother. That's the kind of thing that really damages, in a lot of ways, the workforce and makes it pretty challenging to keep, coming back to work day after day. So I think we're doubly challenged with COVID because of the time frame that it has spun itself out on and will continue because, as Dan says, we know that this is not just going to end at any point in the near-term future and maybe with us in echoes for years to come.
Well, thank you both for those comments. We do have some questions that are coming into the Q&A. Jeff Rubin has asked, are there any data on degree of effect of modified EMS dispatch protocols, including no transfer alternatives, on ED or EMS capacity? Is it substantial or a drop in the bucket? And he clarifies that he's really questioning now specifically to COVID rather than a generic question on EMS protocols. So Dan, do you want to start with that?
Yeah, so Jeff, thanks for the question. Unfortunately, and I'll defer to John, who may know this literature a little bit better than I do, but my understanding is there really hasn't been an effective study that demonstrates what the outcomes, when we talk about outcomes ultimately being the result of a change in EMS transport decision-making, that substantiates this as anything other than what sounds like a good idea, but without the evidence to back it up. John, are you familiar with anything more specific around those a change in transport recommendations?
No, it's a great question, and Jeff, thanks. There's a multi-layered question here. At the dispatch level, if you use a medical priority dispatch system, unfortunately, Card 68, which is the pandemic, card, does not really do a great job in heading off EMS responses. And I think for most COVID responses, it's difficult not to send somebody out to do an assessment. I think if you get down to a certain point, there is some, valid considerations for using, oxygen saturations and other symptoms as grounds for either a no transport or to be transported. At the same time, the literature is pretty replete with the fact that the paramedics are, in general, not very accurate about making assessments for what needs EMS transport and what winds up being more complicated at the hospital than appears to be so on scene. So, I would take all these things with a bit of caution. There are some pretty good crisis standards of care resources available on ASPR Tracy, some specifically in the EMS domain around how to do some degree of call triage and response triage if you don't have an emergency medical dispatcher to, help walk through. But I think in some of the most successful systems, it really does, like CETRAC in South Texas, it really does take a medical provider, a physician, who is helping, address the calls and address the needs of EMS to make the on-scene or over-the-phone determinations of, what responses must be prioritized when we're in an overload situation, knowing that over the course of months and months, EMS may vacillate between a crisis standards of care response at 3 o'clock in the afternoon and being back in a conventional response by 3 o'clock in the morning, only to return to, crisis mode by the next afternoon. So, I think lots of variability really has to be a phased approach, but, looking carefully at what response assets go on, what responses. Do we have to send fire, police, and EMS on the responses we're sending them on, for example, splitting and using the resources in the most effective way possible. But from the COVID experience particularly, I don't know that we've really got a whole lot to draw on from the literature, so sorry. I may not have specifically answered your question, but at least hopefully gave you a few things to think about. But you're a thinking man, Jeff, so keep up the good work, sir.
Well, thank you, John and Dan and Jeff, for the great question. There's a question that I know you didn't cover in this particular document, but it relates to international reciprocity for healthcare providers. Do you want to comment on any ideas you personally have on this question, or should we not delve into a very complicated topic that really covers many situations? So Dan, do you want to comment?
Yeah, I'll make a brief comment. In fact, because I did some work around this in the context of developing a schema and a recommendation for being able to bring international health assets into the United States, again, primarily for a sudden onset disaster like the New Madrid earthquake or another similar type event. The issue is addressed most recently, as I understand it, in what's called the International Assistance System, which was put together by Department of State with all of the other federal interagency partners contributing to that IAS. And of course, the issue during a pandemic is that we're facing a global crisis. And so in this case, it's a little bit less relevant, but I appreciate the question because I think it remains an area that is still worthy of further evaluation and consideration, because there may come the day where we are going to need partners to come, whether they come from Canada or from Mexico, or other, close allies who can support us regionally, or from elsewhere across the globe. So IAS, International Assistance System, would be worth taking a look at.
Dan, thank you. I'd like to direct the next question first to John, and that really has to do with a question. It's Deborah DeBrun raised the question of whether you could imagine that the staffing shortages could become so acute as to mandate denying some patients access to necessary services such as ventilation or other intensive care. Do you have any comment on this? Is there a point at which staffing simply cannot stretch?
Great, and thanks and shout out to Deb for being such a great colleague here in Minnesota and doing such great work with the COVID Ethics Center at the request of Minnesota Department of Health. I believe that aside from some of the binary, supplies like ventilators, that with staffing, we will be elastic enough to, deliver the vast majority of critical care to at least the degree possible. Now, I am concerned that we're going to get to a risk standpoint where we are going to miss things, where people are going to have untoward outcomes because we didn't recognize deterioration soon enough, we didn't do some things soon enough. But I don't think we would categorically exclude people, from critical care based on that. At the same time, I think there are certain categories of service that probably would be excluded on both ends of that spectrum. For example, ECMO is so resource intensive that it might come down to, and this again should be a regional decision, not an individual hospital decision, that the commitment of resources to ECMO for the number of people served just really cannot justify the staffing cost at the time. And also we might see services, and again this would be electives, this would be outpatient services, a lot of other services that might have to be curtailed in order to apply the full spectrum of staffing towards inpatient care and critical care. Again, understanding that the risk of having a clinic nurse taking care of an inpatient is tangible and yet can be reduced significantly by proper onboarding, by proper mentoring, by proper supervision. And so it's in all of our best interest to figure out how we maximally leverage staff. But I think, Deb, directly to your question, I don't foresee a time where general critical care that we would exclude someone from that on the basis of staffing per se. I think it's going to have to come down to the availability of some of the more binary and discrete supplies. And that's why staffing gets to be so difficult to compare between institutions as to what degree have you stretched your staff. And so the use of ancillary providers, the ratios, the team approach, those sorts of things provide some degree of comparator of the degree of duress that the staffing is under.
Thank you very much, John. Dan, I'm going to turn to you for the start of the next question in the interest of trying to get as many questions as we can within our time. We have a question from Christy Kessler, and in a way it relates to the dual messaging we've given about managing and working with staff. On the one side, you're saying, be careful of burnout, be aware of the incredible demands on staff. And then particularly in the discussion, I think it was John who raised this possibility that younger staff may just feel like they need to go out, they need to relax, they need to be with their friends. How would you recommend the leaders in clinical settings, in hospitals and others, have these conversations with staff about both their needs and their obligations?
Yeah, it's a great question, and obviously it's a challenging situation because we're all people after all, and we want to live our lives even in the midst of this crisis. And I can tell you from the work that I did for many years in the Inova Health system, we put a document out and we reiterated it every year called "Caring is Preparing," where we showed a demonstrated commitment on a part of the leadership, whether it was nursing leadership, physician leadership, or C-suite leadership, to the workforce with regards to supporting their well-being and their needs. And it took the shape of everything from discrete commitments to the best possible PPE that was available. For example, in our health system, we made the move towards elastomeric respiratory protection as a means to show commitment to protecting the workforce, to making sure that there was access to gyms or Saturday night movies or what have you. Now, in the context of COVID, that has changed. The incentives have changed a little bit because we are all supposed to be much more cognizant with regards to how we socialize. But I think it is a matter of setting the tone from the leadership and making sure, number one, that the leadership is visible and that they are participatory in what is happening within the four walls of their institution, and that they take the steps where they can to demonstrate that they are leaving no stone unturned to provide as much resource support for their staff as possible.
Well, thank you, Dan. John, I'll turn back to you for a question from Juan Peyorano, who asks, what has been your biggest challenge in COVID-19 staffing, and how did you solve it, or how are you solving it?
Well, great question. And again, fortunately, our hospitals have not been burdened to the degree that some were in New York and other, locations, Florida and Texas and Arizona. But I think we've learned some really common lessons across that. Critical care nursing and respiratory therapy have no question been the key bottlenecks. And to the degree that those problems have been solved is through a combination of contract staffing, sharing healthcare providers across healthcare systems when that hospital is part of a parent system. Moving staff, within that system has been, definitely a contingency. And then again, asking those providers to step, over, especially from post-anesthesia care and anesthesia care, where the CRNAs and the nurses in the post-anesthesia care unit have been invaluable to assisting. And really tailoring what respiratory therapy is doing, because they often are doing oxygen saturation checks, or doing nebulizers, or doing a whole variety of things besides helping out with ventilators. And most of those things are very low impact from a clinical outcome standpoint, and you can train people easily to do those, whether it's administering a meter dose inhaler, or checking a fingertip O2 sat, cutting out things like induced sputums and other more routine outpatient stuff, and just focusing all of the RT time on ventilator management, and asking others who routinely manage ventilators to also step into that breach and assist them. So again, stepping up, stepping over, contract aid within healthcare systems, I think have been the major, methods by which the systems have adapted, and moving towards those more tiered staffing approaches as has been done in New York City and other locations.
Well, thank you very much, John. Dan, let me turn back to you for questions that have come from Amy Berman. First, she's wondering, are we really still timely with these strategic discussions? And although she goes on to acknowledge, yes, they really can be valuable, she's wondering, do you see innovations coming along that could affect our ability to respond to the staffing need, or are we just going to have to do with what we have?
Yeah, thanks. Thanks for the question. I think, so first of all, it's never too late even to put in place the sorts of strategic recommendations as we've tried to outline in this paper. Unfortunately, I know nobody's going to want to hear this, but as I think about this crisis, I recognize that we live in an age of epidemics. And in fact, this isn't even the pandemic we were planning for. Remember, we worried most about a pandemic influenza. So I think that we can learn from this experience. We indeed can benefit from implementation of some of these strategic decisions even now. And I think with regards, if I understand the question correctly, with regards to innovation, a lot of work that I've done around digital health and the use of wearables and remote patient monitoring capabilities and other means of standoff physiologic evaluation is really now, I think, at the forefront of what will be a transformational change in healthcare service delivery. It has been trialed in the use of management and oversight of chronic patients, and I think that there's going to be a lot more that we will see available to us to help alleviate some of the stresses and strains with regards to the sorts of staffing concerns that we see now. So I think it's a great question, and I think we will benefit both in the near term and in the longer term with some of these recommendations.
Dan, thank you very much. I notice on the time that we've actually come to the hour. There are just two other questions, and I don't know if you want to comment just very, very briefly. One question is really whether being part of a coalition actually helps, and how many hospitals in the country are parts of coalitions as opposed to independents. Do you have a comment on that?
John may know the numbers better. I know there are over 400 coalitions, maybe 420, 430 coalitions across the country. John, you may have those numbers more readily available.
Well, I think the key thing is that even though about 90% plus of the hospitals in the United States identify as part of a coalition, those coalitions have vast differences between their level of functionality and operational responsibilities. So some have very robust staff sharing agreements across, the coalition entities, and some do not. And some are able to coordinate that in real time, and some, in fact, I would say most probably do not, which is unfortunate. Now, being part of a healthcare system, a corporate entity, which may cross, coalition boundaries and may cross state boundaries, that offers tremendous advantages, within systems as far as transferring staff. So some of the major, healthcare entities nationally have moved staff between states, taking advantage of some of the emergency licensing, powers and executive orders, and that has worked significantly to their advantage, which has been a real relief for those systems. So I think there's two elements: the healthcare coalition, that is the hospitals, public health, EMS, and emergency management working together at the local and regional level, and then the healthcare systems that may work within just that coalition or may cross coalition lines or even state lines. Both can be leveraged to the degree that they are operationally capable of doing that.
Well, thank you, John. We have just one last, but it's such an important point. It came in actually on a chat rather than through the question, but Amy Callahan is raising a very important point about public understanding and public input into decision-making about crisis standards of care, and specifically perhaps including staffing. And she raises the question whether family advisory boards, for example, have a role, and particularly how does one make sure the public is also a part of this deliberation? Dan, we'll turn to you for a final comment on that really important question.
Yeah, well, thanks. And Harvey, as I think we both, well, all of us on this call agree, this is maybe one of the most fundamental portions and elements of crisis standards of care. And indeed, in our 2012 report, we highlight some of the key fundamental steps that have to be put in place. The first being provider engagement, but the second being community engagement. And so to Amy's excellent question and recognition of the public role, I would point you to the 2012 report. We have an entire toolkit on community engagement for crisis standard of care decision-making. Within that toolkit, in fact, we have an entire scenario focused on pandemic response and decisions around life-sustaining and life-saving resources like ventilator use. And I think that I'll just give you my own sort of editorial opinion. If there was one real missed opportunity, it was to do much more public engagement and provider engagement on the work that we accomplished over the last 10 years on crisis standards of care planning. Now everyone is interested in it, and so I hope, like the last question that was asked by Amy Berman about the benefits of strategic implementation of these plans. It's never too late to start. It may be hard to do that in the midst of a crisis, but we ought to be thinking very, very seriously about how to make sure that we hear the public's voice, the community's voice in their interests in the decision-making going forward, particularly around scarce resources. And that will include access to therapeutics and then vaccine when it's available. So I think a critically important point.
Dan, thank you so much for that comment. I think now we'll conclude the webinar. Scott Wallach has helpfully indicated that the recording and slides will be available after the final session of the webinar tomorrow. Scott, is there anything else that you want to add before we formally conclude? If not, let me again thank especially John Hick and Dan Hanfling for their excellent discussions and particularly for their work. We're very grateful, Matt, to you again and your colleagues at ASPR for all the efforts that you continue to apply to help all of us manage through the pandemic. Thank you all for participating. We'll look forward to the follow-up with those who wish to contact us after the webinar. For now, we'll conclude. Bye-bye, everyone.
Thank you. Bye.